With me, I have Dr. Anirudh, Dr. Bhosle, and I hope all the speakers are there. We'll call serial wise. In case you are absent or somebody is absent, please send them a message, call them. They can present as and when they come in. So can I have the first speaker, Dr. Shumangshri Paul, on safety and efficacy of injection aflibercept intravitreally in retinopathy of prematurity. What are the rules? So your paper is for 5 minutes. So before you present, make sure that you tell us your number, your membership number.
So P18018.
Okay.
I think you can start.
Yeah. Good afternoon. I'll be sharing my free paper. Introduction. ROP is the leading cause of preventable childhood blindness. The incidence of severe ROP is increasing due to increased survival rate of small premature infants by the improved NICU care. So laser is the gold standard of treatment in severe ROP, but intravitreal anti-VEGF agents are being increasingly used nowadays for ROP with posterior disease. So there are several studies and trials which showed the fact that anti-VEGF agents are equally effective and not inferior to the laser treatment. Like BEAT ROP study, where bevacizumab was used, Rainbow trial where ranibizumab was used, comparing the laser treatment. Then the Firefly Butterfly study where aflibercept was compared with the laser treatment, followed by FDA. After that only FDA approved for the aflibercept in the treatment of ROP. Then there was a study for comparing the standard dose with the low dose in the scarcity of the systemic absorption by the VEGF causing VEGF suppression, which showed that standard dose does not have that much of neurodevelopmental delay, but low dose can have high chance of recurrence and inadequate response. So the aims and objective of the study was safety and efficacy of injection aflibercept in the treatment of ROP. So it was a retrospective case series of 22 eyes of 11 babies. Aggressive ROP, threshold ROP at zone 1 and posterior zone 2 were taken. Indirect ophthalmoscopy was done for all the babies, and fundus photo with 4x camera was taken as when possible. Informed consent was taken from the parents, and the detail of treatment was explained to them. Injection aflibercept was given standard dose 1 mm from the limbus intravitreal in the OT care under pediatrician supervision. So post-injection babies were followed up weekly basis to assess the following signs of regression of the severity of ROP at 1 week, need for second injection or rescue laser, progression of vascularization to the higher zone, incidence of recurrence reading laser treatment, number of eyes showing complete regression, or any ocular or systemic complication. So the mean gestational age was 29.27 weeks, mean birth weight was 1217 grams, 16 eyes had aggressive ROP, 6 eyes had threshold ROP, 18 eyes were in zone 1, 4 eyes were in posterior zone 2, and all eyes showed signs of regression at 1 week post-injection. The second intervention, 6 eyes required repeat injection. The mean time interval was 6.3 weeks. 18 eyes received laser treatment. 1 eye developed stage 4B ROP requiring vitrectomy surgery, is doing well at present. So among the laser group, 9 eyes showed signs of recurrence. The mean time of injection and laser was 8.8 weeks, and 6 eyes laser treatment was initiated at 5 weeks post-injection due to the severity of ROP was high in the initial presentation. 3 eyes showed persistent avascular retina up to 16 weeks post-injection, treated later on with the laser. But complete regression following single injection could not be assessed as the extent of regression was different in different eyes, needing second intervention. So this is the consolidated data showing most of the babies were in AROP at zone 1, and the smallest baby was 25 weeks at 680 grams, and the largest baby was 33 weeks at 1940 grams. So this table is showing at first initial intervention, the babies were at the zone 1, which progressed to zone 2, 85% of them progressed to zone 2 second intervention. So this is the picture of pre-injection, zone 1 APROP with plus disease. after the injection, there is signs of regression and progression of vascularization to the higher zone. So the baby developed cystoid macular edema 6 weeks post-injection in the right eye, which resolved spontaneously in 1 week. Left eye did not show any CME. The baby already had systemic CNS CMV infection, and there was a chorioretinal scar. So it was not taken as a complication to the injection per se. This baby had very severe ROP at posterior zone and did not show adequate response following injection, and the second injection was given. Even then, there was not progression of vascularization anteriorly, so the laser treatment was done, which showed complete regression. So to discuss the higher binding affinity of aflibercept to the VEGF receptors causes quick induction of regression, intermediate molecular size leads to longer duration of action, maintained regression with late recurrence, continuous progression of vascularization to the higher zone, the less area of laser, hence less structural damage, no systemic side effects like neurodevelopmental delay related to any possible systemic VEGF suppression. So to conclude, aflibercept injection can safely be used in various types of severe ROP in zone 1 disease, and extent of regression may vary case to case with the severity of ROP in initial presentation. Repeat injection may be required, chances of recurrence is there, longer duration of action, so less amount of laser is required. So they should be followed up very closely and diligently to monitor the extent of regression and disease recurrence for second intervention. Thank you.
So, good study. I have 1 or 2 questions for you. One is, most of the babies you had injected around 32 weeks.
Yes.
And your mean interval at which a second injection or a laser was done was 6.3 weeks.
Sir,
Which was, that means it was about at 38 weeks, 38 to 39 weeks you had given the injection or done the laser. So
laser was done even, most of the laser was done even later on, like 8 weeks, after 8 weeks of post-injection.
So that is about 40 weeks.
Yes.
Fine. So what was the indication? Because by that time of 38 weeks, it would have gone to zone 3.
No, sir, there was, that 9 eye showed signs of recurrence. So that is why we did the laser. But they had gone beyond zone 2, that's why we done the laser.
And you showed that the laser was done up to 16 weeks.
That is a persistent avascular retina was there. So that we had treated with the laser.
That means around at 48 weeks from the time for the
up to 56 weeks also.
You did laser.
Yes.
So generally the laser, once the baby becomes beyond 46 weeks, it is a big baby. Doing laser is not very easy.
But there was a very small area at like zone 3, maybe 2 clock hours maybe, so we did not want to leave it.
Thank you.
In one case, you had showed there is a cystoid macular edema.
Yes.
So, what is the possible explanation in like after the injection?
Yeah, actually it came 6 weeks post-injection. It was an incidental finding. After the injection, there was no CME. But we saw clinically, so we did the OCT actually, and saw that CME is there, but it was there only in the right eye. And that eye only had a chorioretinal scar, and that baby had a CNV infection, serious infection. So we thought that there might be some other inflammatory causes for the CME, not the injection per se. And the other eye also did not show any CME. Actually.
And how do you perform this OCT in this
That flying baby technique.
Thank you.
Next,
Can we have the next speaker, Dr. Shroff, Dr. Rahul Ashok Shroff, comparing efficacy of dexamethasone implant versus subtenon triamcinolone in BRVO, CRVO, and diabetic macular edema.
नीचे कैसे जाता है? एक मिनट. ये नेक्स्ट स्लाइड कैसे जाता है? The important factors for pathogenesis of macular edema in RVO are, besides venous stasis, it is upregulation of VEGF and the release of inflammatory mediators like interleukins, TNF alpha, and prostaglandins. In diabetic macular edema, besides hyperglycemia causing blood retinal barrier dysfunction, inflammation is caused by cytokines and chemokines, and also there's VEGF upregulation due to capillary non-perfusion and microvascular damage. The main purpose of this study was to compare the changes in visual acuity and macular thickness in eyes with macular edema secondary to BRVO, CRVO, and DME in eyes which had been treated with combined therapy of 0.05 ml of bevacizumab with either 0.7 mg of dexamethasone implant or posterior subtenon triamcinolone acetonide. This was a retrospective non-randomized study of 50 eyes of 50 patients with macular edema and with a central macular thickness of more than 250 microns, which was caused by either BRVO, CRVO, or DME, eyes with traction RD, epiretinal membrane, NVD or NVE were not included in the study. 23 eyes had BRVO, 12 eyes had DME, and 12 eyes had CRVO, and 17 eyes had DME. 30 eyes were treated with dexamethasone, and 20 eyes were treated with triamcinolone. In all the patients, initially intravitreal bevacizumab was given, and then after within 15 days, either dexamethasone implant or posterior subtenon triamcinolone was given. And if we saw that there was a recurrence of macular edema at the time of follow-up, then intravitreal bevacizumab was repeated. And this primary endpoint was the change in vision and central macular thickness. So here you can see that this is a heat map of the changes in vision in the dexamethasone group. DME in dexamethasone implant was able to maintain the most stable improvement of vision. Both CRVO and BRVO, the improvement of vision was there till about 60 days, but at 90 days follow-up, there was a slight decrease in vision. Many of these patients we had to repeat the bevacizumab after the 90-day follow-up. In the triamcinolone group, BRVO did much better. They were able to maintain the visual acuity more stably till 180 days. CRVO and DME maintained some improvement of vision up to 60 days, but after 60 days, there was a decrease of vision in both the groups. This is a heat map of changes in macular thickness. Here you can see in the dexamethasone group, here you can see that BRVO and CRVO were able to maintain a decrease in macular thickness up to 60 days. At the 90 days follow-up, the macular thickness had increased, and then a repeat of anti-VEGF was done in some of these patients, and there was this reduction. However, in dexamethasone overall, DME patients did not have a very good change in macular thickness. In the triamcinolone group, however, you see that all the three groups were able to maintain a decrease in macular thickness right up to the 180-day follow-up. So compared to dexamethasone, triamcinolone had a much seemed to have a slightly longer effect. Corticosteroids are known to act by blocking glucostasis, by restoring the integrity of the tight junctions, by blocking inflammatory mediators, and by reducing the swelling in the Mueller cells. Other studies have shown that the OMA study has in refractive RVO has shown that both dexamethasone and triamcinolone both don't have much improvement of vision but have a significant improvement of macular thickness. Other studies done in refractive DME have shown that both triamcinolone and dexamethasone are able to reduce the macular edema. IOP increase was seen to be significant in the triamcinolone group. So between the dexamethasone and subtenons group, there was no significant difference in outcome. However, macular edema decreased significantly in both groups. Triamcinolone seemed to have a longer effect. There was not much change of vision because of the disruption of the inner retinal layers, and most of the studies done so far have been done on this thing old macular edema, which is not responding. So actually, larger studies should be done to find the this thing benefit of early steroid treatment. Thank you.
So what was your conclusion? Combining a steroid with anti-VEGF?
Yeah, no. So so this was early, so that it does have an effect, but this is just a 6-month follow-up. Okay. So actually, maybe a 2-year follow-up will actually show whether early steroids are beneficial, or you should only treat only if it is non-responding.
So now what about the combination therapy?
The combination only. So this combination, so whether this thing combination in most studies started only if they were not responding to anti-VEGF, then you give anti-VEGF plus steroid. In this, I was giving it in the initial time, not waiting for it to become non-refractory.
So it was within 15 days?
I mean, some were 7 days, some were, it was a retrospective study, so some were within 7 days, some were within 10 days, things like that, but less than 15 days.
The previous studies has said that there is improvement in the macular thickness, but there is no significant improvement
because of that drill,
visual.
basically that, because of the factor of drill which is there in macular, that disruption of the inner retinal.
These were all naive cases?
Naive, yeah, because it's saying retrospective analysis. I mean, I've taken only from the first treatment onwards.
So the first, the moment
bevacizumab was given,
walks into a clinic, receives an anti-VEGF, which is like bevacizumab, and the patient is told that after 15 days...
so actually that is completely economic. Those who can afford DEXA, take DEXA. Those who can't afford DEXA, take Triamcinolone.
Yeah, but all of them get an anti-VEGF in the beginning.
Initially everyone's treated with one anti-VEGF. That's why this thing bevacizumab I've taken, because some were this thing Eylea with DEXA. So I mean aflibercept with DEXA. So those will that become complicated because is Eylea acting better or bit.
And what made you inject the anti-VEGF a second time?
If there was a significant increase in the macular edema at 90 days, because in some patients the dexamethasone implant in some patients wears out at about 3-month follow-up. So then if there's quite a lot of increase, then I used to just give one more injection of bevacizumab.
Was there any difference in the intraocular pressure?
Significant. The DEXA group, the IOP increased after 30 days, because after that they were all put on this thing, IOP lowering medication. So after that, because you can't keep the IOP high. So the thing is, at 30 days, the mean IOP increase in DEXA was 0.3, and in this thing Triamcinolone it was 4.25. It was significant change.
Can we have the next speaker? Dr. Kirti Rani. Evolution of corneal endothelial cell loss following vitrectomy with different endotamponades.
Good afternoon, everyone. And myself, Dr. Kirti Rani, and today I will be presenting paper on topic evaluation of corneal endothelial cell loss following vitrectomy with different endotamponades. Coming to the introduction, as a vitreoretinal surgeon, we should not neglect the cornea, which is very vital structure responsible for the good functional outcome after a good retinal surgery. In past, there are only few studies documenting endothelial cell damage following vitreoretinal surgery, and none of them has been conducted on Indian eyes. So this knowledge gap necessitates the further investigation. These are various factors which are responsible for the endothelial cell damage during vitrectomy, and out of these factors, endotamponading agent is a very important factor. Aims and objective were to evaluate corneal endothelial cell loss following vitrectomy with different endotamponades in eyes of Indian cohort. This was a retrospective, non-randomized comparative observational study which was conducted in between Jan 22 to March 23, and after taking informed consent from participant and approval from the ethics committee. Inclusion criteria include age more than 20 years, phakic patient, pseudophakic patient with history of cataract surgery more than 6 months, with endothelial cell count more than 1900 cells per millimeter square and willing to participate in the study. Exclusion criteria include pre-existing corneal abnormality, ocular inflammation, trauma, glaucoma, aphakia, zonular dehiscence, complicated RD, and history of multiple retinal surgery. Total 32 patients were enrolled in the study and they were divided into 3 groups. Group A include patient with C3-F gas injection, Group B include patient with silicone oil injection, and Group C include patient with ringer lactate at the end of the surgery. After a thorough ophthalmic examination, a non-contact specular microscope was carried out in all patients with the help of Topcon SP3000P version. And these various endothelial cell parameters like endothelial cell density, average cell area, coefficient of variation, central corneal thickness, and hexagonality was seen in all the patients. And minimum 50 cells were counted, which is ideal for looking for the endothelial cell loss in this patient. During the follow-up period, the non-contact specular microscopy was performed by same machine at 1 month and 3 month follow-up. And coming to the result part, a significant endothelial cell density loss was seen on all the 3 groups, and maximum reduction was seen in silicone oil group. Minimum was seen in patient in which C3-F gas was injected. This particular table is showing that post-operative 3-month follow-up data, and in this we can see a significant difference in the changes in endothelial cell density and the central corneal thickness. However, the difference in rest of the parameters was not significant in between the 3 groups. Coming to the discussion part, endotempering agent, we all know that have a very important role in the reattachment of retina. However, these agents may simultaneously damage the corneal endothelium, leading to the development of corneal decompensation and ultimately poor visual outcome. In past studies, in one of the study by the Goni et al., they have seen significant decrease in the number of cell density in the cornea. However, no difference was seen in the hexagonality and CV. In another study by the Farai et al., they have seen that silicone oil filled eye exhibited a lower endothelial cell density and a higher CV and reduction in hexagonality. In a study by Sinar et al., they have noted any significant difference in the eyes with SF6 or silicone oil endotempering agent. In a study by Common et al., they have seen significant reduction in these parameters, and in their study, the gas component has a superior outcome.
That's what Sir did not.
In another study by Abraham et al., in which they compared silicone oil with ringer lactate, significant endothelial cell density was seen, loss seen in both the groups. In our study, C3-F gas injection has lowest percentage of endothelial cell loss, and silicone oil group has exhibited higher percentage of endothelial cell loss, and these findings are consistent with few of the previous studies. Limitations of our study include short term of follow-up of only 3 months, small sample size, use of ringer lactate instead of BSS, irrigation fluid volume was not measured, and surgical time was not same for different groups. The strength of the study include all the surgeries are performed by same surgeon, same center. Age was matched in patient of different groups. All measurements were captured by same examiner who counted minimum of 50 cells, which is ideal for accurate measurement. Coming to the conclusion, corneal endothelial cell loss after vascular vitrectomy with different endotempanoids is a very crucial consideration in vitreoretinal surgery, and we as surgeons must carefully weight the benefits and risk of different endotempanoids during the vascular vitrectomy to achieve the good visual outcome. This study adds data from the Indian population which was not studied before, and this is the further future research direction that we should develop a novel endotempanoid with less toxicity on the cornea, hence improved corneal outcome. Thank you everyone.
Any specific reason why RL was chosen versus BSS, which is more endothelium friendly?
Sir, might be in this study possible that the patient in which the ringer lactate was used, they are usually diabetic patients. So might be the duration of surgery was more in these patients as compared to the patient with silicone oil. So we usually left, if in diabetic vitrectomy, there is no development of hole during the surgery, then we left the patient under ringer lactate only. So I think that's might be one of the reason, as most patients are diabetic in that group.
And you didn't mention the area of you did manually check, counted 50 cells, right?
Yes, sir.
So what was the central zone you counted? How many millimeters?
Counted in the central 3 millimeter area.
Okay.
So just maybe I missed out, what was the lens status in all your, this thing was uniform? Lens status, they were
No, sir. Sir, some patients were phakic, some were pseudophakic, and if they are pseudophakic, then the duration of the cataract surgery should be at least 6 months. And in studies, sir, we have also compared between phakic and pseudophakic patients. And because of that time lag, I have not included that particular data. But in our study, we have seen that whether the patient is phakic or pseudophakic, the difference between these two groups was not significant.
And none of the patient, the oil or gas migrated into the anterior chamber?
No, sir.
Because sometimes even in pseudophakic, if the zonules are weak, you can have a small bubble of oil or gas escaping into.
Yes, sir.
So you had no patient with this
No,
escape?
sir.
Okay.
Okay. Thank you, sir. Thank you.
You can have the next presenter, Dr. Ritika Agarwal, on subretinal worm with premacular hemorrhage.
Good afternoon, everyone. I'm Dr. Ritika Agarwal, doing FNB in Vitreo Retina. So the topic of my presentation is a subretinal worm with premacular hemorrhage in young and unusual presentation. So a 19-year-old male patient, resident of Malda, West Bengal, presented to us with the complaint of diminution of vision in the right eye for 2 days. And he noticed this diminution of vision in the right eye after waking up in the morning, which was sudden in onset and non-progressive. It was not associated with any kind of pain, no history of flashes of floaters, no history of trauma, fever, or any drug intake. And there was no history of any coughing, sneezing, or heavy weight lifting. The rest of the past history, family history, and personal history was not significant. Coming to the ocular examination, the right eye, best corrected visual acuity in the right eye was finger counting close to face with no acceptance, whereas in the left eye it was 6/6. Intraocular pressure was 14 and 15 in both eyes, and anterior segment was within normal limits. And when we saw the fundus of the patient, then we saw a large pre-retinal hemorrhage seen over the macular area of almost size 6 disc diameters, obscuring the underlying vessels in the right eye. And the background was within normal. Rest of the background was in the normal limit in the right eye. Whereas in the left eye, the fundus was within normal limits. And then we needed to know the cause of this pre-retinal hemorrhage. So we did the fundus fluorescent angiography. And starting from the early to the late phase, there was a block fluorescence which was obscuring the underlying structures. So there was a large pre-retinal hemorrhage corresponding to the large pre-retinal hemorrhage. There was no focus of neovascularization that we could find in the right eye, maybe due to the obscuration by this pre-retinal hemorrhage, and we could not find whether it was only a pre-retinal hemorrhage or it was accompanied by a subretinal bleed. So we did another test to rule out what was the cause of this problem. So the rest of the tests like CBC and coagulopathies, there was no history, also in the coagulation profile was within normal limits. So as the patient was very anxious and we could not find whether it was accompanied by a subretinal bleed also, the patient opted for surgery in view of early rehabilitation. So right eye pars plana vitrectomy with endolaser was done in this patient under local anesthesia. And when we did PVD induction, this hemorrhage got dispersed into the vitreous cavity, which was then extruded. And when we found out that there was a white glistening band-like structure present in the subretinal space, and there was also a bleed near the disc, so we left it untouched. And this is a fundus photo on the post-op day 1, where the visual acuity was 6/12 parts, and intraocular pressure was 12 millimeters of mercury. And as you can see, there is a white glistening band-like structure present in the subretinal space, which we could not find out what was it. So we did an OCT examination at this level, and we saw there was a rounded structure present in the subretinal space at that area. And there were two possibilities, whether it was a subretinal band or a worm. So because of this rounded structure present in the OCT examination, a strong possibility of subretinal worm was considered. So we did further investigations like peripheral smear and filarial antigen test, which was done at 2 a.m. in the night, and that was found to be within normal limit. But the absolute eosinophil count was more than the normal. It was 720 per microliter. The patient, since it was not moving, this thing was not moving with respect to the light, so it was considered to be a dead worm. And the patient was started on oral corticosteroids without any antihelminthics on tapering doses. At the post of 1 month, this structure of this worm got faded away after 1 month of the follow-up, as you can see in this OCT picture. So the favoring points in my diagnosis is there was no predisposing factor in this patient of 19-year-old male that led to this big preretinal hemorrhage. There was presence of peripheral eosinophilia. OCT findings revealed a rounded structure present in the subretinal space which got faded away with the help of corticosteroids, and the patient belonged to an endemic area which is endemic for Vitreo area. So there is a condition called diffuse unilateral subacute neuroretinitis, which is a clinical syndrome which is caused by motile, white, glistening, non-segmented nematode wandering in the subretinal space, and it occurs mostly in the children and young adults with a period of activity and remission. So there is an early phase and a late phase, which is vitritis, and in the late phase it is followed by optic atrophy and narrowing with major retinal vessels. So many worms have been studied in the past, like Toxocara, Ankylostoma ascaris, Strongylitis, Baliascaris. So these are the various case reports that have been published in the past. This is the Toxocara canis case report, in which they treated it with only oral antihelminthic drugs. There is a subretinal worm present in the macular area. And then there are other case reports in which in the macular area there was subretinal worm, and it belonged to Baliascaris, and it was treated with laser photocoagulation. Similarly, there were case reports on Vitreo area, in which it was found in the anterior chamber, causing panuveitis. And there was a subconjunctival worm in subconjunctival space also. Other case reports when the onchocerca was present in the vitreous cavity and was extruded with the help of a pars plana vitrectomy. Other case reports of echinococosis.
Need to conclude.
Okay. Yeah. Yes. So the take-home message is that early diagnosis and treatment of diffuse unilateral subacute retinitis leads to a better visual outcome, and it should be kept as a differential diagnosis in the young patients. So laser photocoagulation is an effective method to halt the progression of this disease, and systemic treatment have an inconclusive role in destroying the live worms in few patients. Thank you, sir.
What is the possible mechanism of this subhilar hemorrhage?
So the possible mechanism that we thought that it went into the choroidal circulation systemically, and then it went into the subretinal space from the choroid, and then it ruptured. The vessels got ruptured. So it led to the preretinal hemorrhage. Firstly into the subretinal space and then into the vitreous cavity. Various case reports have been published when the worm has migrated to the vitreous cavity through the ruptured blood vessels.
Picture, the
Yes, sir.
worm was predominantly subretin pre-RP, is it?
Pre-RP, yes, sir.
But it was sort of between the neurosensory retina and RP.
So clinically it was found to be subretinal, but in the OCT figure I thought that it is subretinal or intraretinal, like it is present before the pre-RP, but it is present, like I cannot find this neurosensory retina here in this figure.
But tell me, sir, how did it disappear after a few weeks?
So it was considered to be it was like hypothesized to be a dead worm because it was not moving with the light.
Body finished it off.
So we gave a tapering doses of oral corticosteroids. So it was to contain the inflammation. That is, the natural course of the worm is like that only, that it gets disintegrated in the later stages.
What was the B-scan picture like before the surgery? I did not catch the B-scan picture before the surgery. Did you do one?
So B-scan we did, but I don't have the picture. There was no retinal detachment that was associated with it. So the main thing was that we could not find whether it was associated with a subretinal bleed or not. So that's why the surgeon went ahead with the surgery.
And you are very sure that it was a worm, nothing else, no subretinal bleed?
So we are not sure. There was a strong possibility of a worm. Actually, we do not know what is it. So the strong possibility of worm was considered with the help of these favoring points. So we are not sure.
Okay. Thank you.
Thank you, sir.
So move on to the next speaker. Retro mode, newer insight into dry AMD by Dr. Shilpi.
For this opportunity, I will be speaking on retro mode. Does it provides newer insight into dry AMD? We all know AMD is the third leading cause of irreversible blindness, and the main sites of pathogenesis are Bruch's membrane and RPE. Drusen's are the extracellular material deposited between RP and Bruch's membrane. And as we cannot detect the drusen size less than 25 microns, so the various modalities were explored so that we can detect the drusens. Retro mode, it is a new investigative tool in the basket of all the investigations we have, and it specifically images the RPE. It uses infrared lasers and in this the apertures are laterally deviated so that only the reflected light is taken from the structure. Various studies have shown the advantages in the form of it is a sensitive modality, it gives directional information, it has the accurate characterization of retinochoroidal deposits, and it can detect smallest alterations. So the aim of our study was the role of retro mode in early detection and to compare it with other pre-existing available modalities on multimodal imaging system in dry AMD. So it was a prospective observational study on 409 eyes. The exclusion criteria main was the drusen size less than 63 microns, because when we counted the drusen, the number of artifacts or the false count rates are very high. These are the various pictures of the multimodal imaging in cases of no AMD, early AMD, intermediate. We also did the EDI, OCT and OCTA, that is ocular coherence tomography, angiography, and vessel density in the 9 quadrants of ETDRS at 4 layers, that is choroid, choriocapillaries, deep and the superficial retinal vessels, so that we can compare it with the established modalities. Number of drusens were counted using a software .count2, and also it was then processed by using ImageJ software. Now coming to the results and discussions, the demographic profile between all the groups was not significant. When the number of the drusens was compared in the color photo, FAF mode and the retro mode, the p-value was significantly high for the retro mode and the FAF mode. On the individual comparison, retro mode was superior to color photo. FAF was also found to be superior to color photo in detecting number of drusens, while when we compared the retro mode with the FAF, it was found that only in the intermediate stage, retro mode was found to be superior. We also studied the extent of the disease based on these 3 multimodal imaging modalities, and in cases of early and intermediate EMD, the retro mode was found to be superior compared to both the color photo and the FAF mode. The thickness of the choroid and choriocapillaries, it decreased with the increase in the severity of the disease, as is already established. And when it was plotted against the line curve, it is seen that retro mode was most sync according to the OCT EDI. Vessel density, when it was compared with color photo on the various levels, that is choriocapillaries, superficial level, deep, and also at the choroid level, it was seen that it was only the retro mode which was in sync with all the established modalities like OCTA and EDI OCT. So to conclude, it is found to be better diagnostic modality than color photo in detecting more number of drusen. It is found to be better diagnostic modality when we compare the area of involvement. It was more correlating with the OCTA and the EDI, which are the established modalities. Though superior, as found in our study, this mode cannot replace other modalities at present, and it only acts as a complementary investigation in early detection of the disease. The limitations of the study are it is a cross-sectional one-time study. Longitudinal studies are needed to prove the superiority and artifacts, and therefore the false positive counts cannot be eliminated. Thank you so much.
Study Shilpi, I have 1 or 2 questions. Retro mode on the Mirante has 2 options. There are 2 types of retro mode. So, and autofluorescence is also green and blue. So, which one you compared?
So, all the 3.
All.
DRDL, directionally right and left, deviated right and left, and also blue and this green and
okay.
Blue.
And when you looked at the OCT, you looked at the cross-sectional image or B-scan image or the unfast image?
It's a cross-sectional image.
Because when you have drusens on a cross-sectional, the difference between 2 lines is 300 microns, is 0.3. So you might miss drusens in the middle.
Yes, sir.
You may say you take an HD20. So I'm thinking in terms of Zeiss, but I don't know. Yours is this thing. When you do a cross-sectional, can you do seamlessly throughout without missing any area on a cross-section?
Yes, sir.
It's a line.
It's a line scan.
So I think unfast would be a better, because as sir is saying, you would not be missing any in-between lesions, because those again will be significant.
Yeah.
Okay.
Unfast might be, unfast will give you a uniform. So you can have an unfast of every layer and on that, when you plot it out, so you can even get that image and put it on image J, and you can plot out and then compare it.
Okay, sir. We
Just a
actually
sec.
did manually instead of that, so that
Yeah,
was
it's just a suggestion.
Yes, sir. Thank you. Thank you so much.
Move on to the next speaker. Impact of telemedicine and ROP screening in rural outreach in South India by Dr. Abhishek Das.
Red cell distribution with and was sent to the central laboratory. RDW SD and RDW CV are estimated by automated cell counter. In this study, RDW CV is taken into account. The machine that is used in our department is Sysmex 550 6-part cell counter. So this is the figure showing the age distribution, where 51 to 60 years of age group presented with mild NPDR, whereas 61 to 70 years mostly presented with moderate NPDR. There was no significant distribution between the gender. This table shows the relationship of severity of NPDR with duration of diabetes mellitus, where as the duration increases, the severity also increased. So more than 5 to 10 years presented with mild NPDR, whereas more than 10 years presented with moderate NPDR. And the p-value was found to be significant, which was calculated with Fisher-Exact test. Table 4 shows the relationship between HbA1c and the severity of NPDR, where with the increase in the HbA1c level, the severity also increased, and this p-value was also found to be significant. Table 5 shows the relationship between RDW and the severity of NPDR, whereas 11.6 to 14% of RDW range has mild NPDR cases, whereas more than 14% has moderate NPDR cases. So statistical analysis that was used was the qualitative data, descriptive statistical analysis. So in this study, out of 38 cases, 9 cases have no diabetic retinopathy, that is 23.6%. 15 cases have mild NPDR and 14 cases have moderate NPDR. Of 15 mild NPDR cases, 73.3% cases have RDW of 11.6 to 14% range, and of 14 moderate NPDR cases have RDW more than 14%. So in our study, we found a significant increase in red cell distribution with increasing severity of non-proliferative diabetic retinopathy. RDW also predicts the uncontrolled glycemic status because it correlates well with the HbA1c and blood glucose levels. P. Bhupati studied the association between red cell distribution with a neutrophil lymphocyte ratio in the early detection of diabetic retinopathy. So from our study, we conclude that red cell distribution width could be a potential diagnostic marker for screening and to predict the severity of retinal damage in diabetic patients. So considering the huge diabetic population, it is difficult to screen and diagnose the entire diabetic population. So red cell distribution width can be used to assess the severity of NPDR as mild and moderate grades at the primary care physician level. So these are my references. Thank you.
Did you see any one-to-one correlation between the RDW and the chronological diabetic age of the patient? Say the patient was diabetic for 5 years, 10 years. Is that significant or is it important?
So, with duration, there was no correlation found directly with the RDW levels, but with the severity of diabetes as it increases with the duration, so indirectly there is a correlation. So indirectly we can say that it is significant, but direct correlation was not found. Thank you, sir.
Next, we have Dr. Pushkar Dhir, efficacy of PFCL flap, inverted ILM flap technique for treatment of chronic macular hole.
A very good afternoon, everyone. So I'll be talking on the modified inverted ILM technique versus the normal inverted ILM technique in cases of chronic macular hole cases. Before I start, I would like to acknowledge Dr. Chintan Desai, who is also here in the room, who has persuaded me to try this technique when I was facing a lot of macular hole closure failure. So going on to the technique which I'll be discussing, there's no financial closure. So as we all know, that inverted ILM technique was well started by Michalowski et al. In 2009. And in the method, ILM was not completely removed, but a small remnant was left at the edges. And multiple studies have reported a superior result as compared to the conventional technique, where the whole ILM was removed from the whole edges. So ILM flap technique is limited by difficulty in maintaining the inverted ILM flap inside the hole during the FAE, fluid air exchange, and with high rate of accidental ILM flap detachment during the procedure. Though we all try to do it with a minimum of vacuum, but still there is chances of iatrogenic removal of the flap itself while doing the FAE. So my aim was to evaluate the efficacy of modified inverted ILM technique versus the normal ILM technique, and we did it at Eye Care Center in Bhiwani, Haryana. The study design was retrospective interventional study and did for 2 years. In this, 11 eyes of 11 patients underwent the standard 3-port 23 gauge vitrectomy. And in this procedure, after folding of the ILM, what we do in a conventional, inverted ILM technique, approximately 3 ml of PFCL bubble was injected over the ILM flap, forming a PFCL cap. And that helped in retention of the flap inside the macular hole during fluid gas exchange. The preoperative and postoperative visual acuity were measured at 1, 3, and 6 and 12 months. And the results were really good after this study, which I'll be sharing subsequently. So quickly moving on to the technique which we did. So after the conventional PVD induction and the staining of the macular hole with the BBG and the normal inverted ILM flip technique is being done. So once we have peeled off the ILM in an inverted fashion, even if you are not able to invert it properly, still, if there is even a flea flap, you have to put a PFCL bubble, lower the IOP, and then put a PFCL bubble, and whatever flaps are there inside the vitreous cavity, just drag on the flaps from the side into the macular hole itself, and you will see a closure of macular hole on table itself. And then you have to carry on with the FAE gradually. These are the 2 cases which I have shown over here. So you can see that in both of the cases, you can see the ILM put inside the hole, and the hole has a closure on table. So 11 eyes of 11 patients were included, out of which 33% was females and 67% were male. Majority of the patients were in the age group of 50 to 70 years, with minimum linear diameter of macular holes was 811.4 microns. Preoperative visual acuity was 1.2 logmar. Mean postoperative visual acuity after 12 months of surgery was 0.56 logmar. The statistical analysis confirmed that there was a significant difference in the visual acuity between the preoperative and the postoperative results. So we confirmed that the closure of the macular hole with spectral luminosity was, in this case, were 100%. The closed macular hole had a better configuration. It was U-type more of rather than the V-type, and there was significantly increase in the visual acuity also. So these are the different cases where we have done the same technique. The discussion part, the present study observed that the mean postoperative value in these cases were significantly improved. According to Michalowski et al., there was high rate of accidental ILM detachment during inverted ILM technique. Our study also found the closure rate of macular hole by this technique was 100%. And our study demonstrated that closed macular hole has a U-shaped closure which is associated with good visual vision. Conclusion, we present a modified ILM flap technique to improve retention of ILM flap inside the macular hole and improve the reliability and reproducibility of the operation itself. The limitation is that we have a small study till now, and we'll be continuing it further also. So thank you everyone for patiently listening to this talk.
So one of the cases you showed free flap.
Yeah, so if there is even a free flap.
So are you stuffing that in the macular hole or just the PFC?
No, we stuff it, yeah.
Because there is always a chance of dislodgement of this flap when you are removing the PFCL bubble as well?
Okay, so once you start removing the PFCL, so what you do is once you have put a PFCL bubble, you have removed the flaps and put it inside the hole. Then you start doing the FAX, you keep the fluid needle over the disc. So gradually, once the last portion, only we are worried about the last portion when the dislodgement occurs. So if you keep it slow, I mean, you keep the pressure low and you keep it slow, you will be able to see that there is no dislodgement. And you have to keep it for 25 to 30 seconds, not that immediately after putting the PFCL bubble and stuffing, you start removing it. So that will can lead to any dislodgement, but it didn't happen in my case. So it all depends how you move the ILM towards the hole and put it inside.
So in any cases you had the subretinal migration of PFCL bubble?
No, not yet. Not yet to be documented till now.
As well.
Yeah. Definitely, there's a possibility.
Dr. Pushkar, I'm still confused about the last part of it. So you start fluid exchange.
Yes.
Then your flute or whatever aspiration backflush is at the disc.
Yes.
Now when the air reaches, until the air reaches the PFCL, it's going to be a round bubble, right?
Yeah, correct.
The moment the air is going to touch the PFCL interface, you are going to lose the contour of the air bubble, the PFCL.
Yeah, the contour will be lost.
So you won't be able to make a difference between the remnant fluid and the PFCL. So my question is, again to the
remnant PFCL,
the remnant PFCL and the remaining fluid is going to mix. You won't be able to make it a difference between both, right? So how does the last part is crucial, and exactly during the last part, your PFCL and your fluid become one. So how is your PFCL helping? How is it different than doing a conventional technique? I hope you got my question.
Yeah, basically the question is about the PFCL mixing and the losing its property of the tamponading, which was already there. So once it touches it, even still that the contour is lost, still the effect is already there. The PFCL has done its effect already. The moment, the time you have kept it inside and done whole the procedure, the PFCL has impacted it. It was supposed to put the pressure on it, it has done its job well. And once you start removing it, it doesn't move.
Okay,
thank you. Thank you.
Thank you. Can we have the next speaker?
Pushkar, 1 second, I have another question. So, more than a question, rather, is just a comment.
Yeah.
First of all, it's very nice what you presented. Thank you for sharing it with us. Now, one correction is that you don't really achieve closure on table.
Sorry?
You don't really achieve closure on table. You're just stuffing the ILM. See, ILM is just a scaffold.
Yeah.
So you're not going to get closure by any chance. Even if you don't stuff it, in fact, it's not recommended that you stuff it in the first place.
Okay.
You just leave it attached and it'll just pick up as a scaffold. And
it will just...
Correct, that's one.
Yeah.
Second, you should also look at why you're getting so many hole closure failures, like you said, because the peel that you showed was a macular excess kind of a peel. Go all around.
Correct.
What I would also suggest is you can start doing something like a 180-degree quadrant, or do it in quadrants, so that you have a residual flap which you're not going to inadvertently peel off. You get my point?
Okay.
So, for example, you come about
make it
180 degrees.
wise.
You do a 180 degrees. That's quite simple. And then do a 180 degrees, and then you have a residual attached area. It's very unlikely that you're going to. I've never had a flap that I've dislodged.
Okay.
So it's not very common.
So you do it for 180 degree only?
Yeah, you can do it to 180 degrees. You can do it for smaller quadrants also, so that you make sure that multiple places that's attached to the whole edge. So and the residual you can remove or just trim it.
All right.
Okay.
I'll try to take it. Thank you for the comment. Thank you.
We don't have any time for questions now, so you're all very lucky. So we'll quickly shoot through the presentation.
I'm sad. There is no questions. That's
We'll ask you outside, Obali.
done. Okay. Yeah. Can I start?
Yes.
So, good afternoon, everyone. So, the topic is intravitreal dexamethasone implant in epiretinal membrane surgeries. This is retrospective analysis. This is not moving. Yeah. So, ERM is a fibrocellular proliferation over the ILM. Development has been an inflammatory process. Some people, recently there are studies which have started using intravitreal dexamethasone implant in patients undergoing vitrectomy. And there are studies which are supporting the above hypothesis. However, there is a limited number of studies analyzing the outcome of the combined procedure. So, as I told earlier, ERM is a non-vascularized fibrocellular contractile proliferation. It is comprised of RPE cells, fibroblasts, myofibroblasts, and it can lead to retinal edema, macular distortion, blood-retinal barrier breakdown, and central vision loss or metamorphosia. So, managing ARMs, the gold standard has been pars plana vitrectomy with epiretinal membrane peeling and ILM peeling. And meta-analysis of the ARMs shows that the cystoid macular edema generally peaks at 4 to 6 weeks after the completion of the surgery. The studies have also shown that intravitreal steroids are capable of accelerating the intraretinal edema resorption and hastening the visual acuity, recovery. So this is Ozurdex is a stable and a long-term this thing to expedite the regression of retinal edema. Now coming to the aims and objectives, to evaluate the safety and efficacy of PPV membrane peeling with a DEX implant with no tamponade. It's only a saline tamponade, and we are not going to give the patient any positioning for the management of idiopathic ARMs. So the primary objective is to see the functional outcome as the improvement at the end of 1 month. And the secondary objective is anatomical outcome at the end of 1 month. So this was a single center retrospective analysis with a single surgeon, and the place of study was center for site, and the duration was the cases we had taken from the past 1 year, and study subjects were 27 patients. All of them underwent 25 gauge pars plana vitrectomy, epiretinal membrane peeling, and intravitreal DEX implant. The methodology, we measured the preoperative BCVA, intraocular pressure, slit lamp biomicroscopy, and fundus examination. This was repeated on POD1, post-op day 15 and post-op day 30. Coming to the demography, so in the 27 patients, we have a predominantly female population. 18 were female and 9 were male, and the mean age was around 57 years. And the preoperative evaluation, the logMAR BCVA was 0.5, and the central macular thickness was 312, and there were a total PVD in 18 patients and incomplete PVD in 9 patients. The procedure, we combined certain patients with cataract surgery. 12 patients underwent with the cataract surgery, and 15 patients went a standalone pars plana vitrectomy. So post-op day 1, you can see that we are not miracle makers. We don't give POD1 recovery. You can see that there is an increase in the edema as well as a decrease in the vision on POD1, and that is natural because the patient has irritation, watering, redness, and so you won't be able to have a quick jump on POD1. But as you can see in this chart, from day 15 onwards, you can see that the best corrected visual acuity average becomes better than the pre-op, and it progressively keeps increasing till the final follow-up of 3 months. And also the central macular thickness, you can see that there is a jump on POD1, but POD15, 1 month and final follow-up, you can see there is a massive reduction in the central macular thickness. Now coming to the results, there was a significant improvement in the BCVA from baseline. There was a significant improvement in the central macular thickness compared to the baseline. DEX implant helped hasten the recovery during the first month. No patient showed any IOP spikes. We have a very small subset of populations. Thankfully, none of them showed any secondary glaucoma because of DEX implant. 4 out of the 27 patients had drill, which was their pre-surgery, and that remained post-surgery, and those patients had a poor visual improvement post-surgery. 6 of the 27 patients, as you can see in this picture, there is a spongiform edema which developed POD15, and it still persisted. Even though the vision became 6/6 in this patient, you can see that there is a spongiform edema which was there, which is still persisting. We hypothesized due to the lack of tamponade, because there is no tamponade, there is nothing to press this edema back. And also there is a tractional stress over the retina which is causing this spongiform edema. Discussion, PPV with gas tamponade has stayed the standard for treatment of symptomatic ARMs. Gas tamponade restricts the quantification of early post-op recovery. Prone position has always been a bone of contention for every surgeon. We say 8 hours, the patient does 2 hours. So we don't know how much of a post-op prone position the patient is able to maintain. Aimed at resolving these drawbacks of conventional procedure, we can do it by saline tamponade and no positioning. These are some of the other studies. This is a study by Hostovsky et al., and they also did they had a smaller sample size compared to us, and they did a gas tamponade. This is Srivatsava et al. In ARVO. They also did a gas tamponade, whereas ours is no gas tamponade. This is a study done, this is also saying that they had the gas tamponade in it. So the conclusion is that our analysis shows that simultaneous DEX implant with PPV could be done safely. DEX implant reduces the severity of post-op inflammation. Closing in saline tamponade provides a fast visual rehabilitation, and clear media enabled us to quantify post-op recovery in a more laborious manner. And cumbersome prone position could be avoided, especially in elderly and patients who cannot maintain it for a longer period. So limitations of our study, there is no comparison group, and the follow period was short, and we need a randomized control trial to validate the data. These are the references. Thank you.
Just one question. In a vitrectomized eye, is any special technique of pushing the ozortex? Because it might injure the retina?
We did
Theoretically,
it in a saline
yes.
filled media. We did not do it in air. We did it in a saline. The saline, the velocity reduces as it goes through that. So we do not thankfully have any retinal
In
injury.
any case of detachment following?
Nothing, sir. Nothing.
Thank you.
Thank you, sir.
So can we have the next speaker, Dr. Chintan Desai?
Good afternoon, one and all. So this topic which I'll be presenting now has been discussed already a couple of presentations back, but I'll try to add on whatever I can to it. So for a very long time, macular hole surgeries have been a standard. For a very long time, macular hole surgeries, ever since they were invented, have been a standard 5-step procedure where vitrectomy with posterior hyaloid removal was done to remove the anterior posterior traction, followed by ILM staining and peeling to remove the tangential traction, then a fluid air exchange, followed by gas in a face down positioning. Now this technique, although it became very popular and it gave a lot of success, it had another step to it, which was praying to the laws that the flap sticks the next day. So then OCT came and various biomarkers were invented which actually gave us prognostic factors for anatomical success, and it was realized that a lot of medium to high large diameter macular holes were actually not closing completely. So various techniques were invented, the most recent being the conventional, the ILM peeling, making it ILM flaps, which provide the fibrocellular network for the hole to close. And although this technique significantly improved the success rate, more than 90% with most practitioners, there was still an unpredictability about the hole closing because of flap-related complications. Now, losing a flap can happen in various ways. You might be trimming the flap at the end of the surgery in the lowest of vacuum and the highest of cut rate, but still there is a possibility that you might dislodge the flap. If you don't do that, then even during the fluid air exchange, the flap might get away from its normal position over the fovea. And even if that is okay, then maybe the next day under gas, the flap might displace from its normal anatomical position. And these are the reasons why various viscoelastic substances came into vogue, where people started using these viscoelastic substances to keep the flap in place. But all of them had limited success. So then that got me thinking about what else can PFCL be used. So this is a video of a surgery where there was a macular hole with retinal detachment where I used PFCL, and as you can see here, notice the change in consistency of the ILM flap as soon as it comes in contact with the PFCL. It becomes sticky, it becomes easily maneuverable, and it's almost like a stuck-on appearance of the flap over the macular hole. So this, along with this study that I came across with Dr. Vishal and all, they didn't use PFCL exactly for this purpose, but they used PFCL for easier ILM peeling, and they also mentioned that the ILM changes consistency. It becomes sticky, it becomes easily maneuverable, and it stays over the macular hole at the end of the surgery much better. So this is one of the first cases where I've employed this technique. This is a 63-year-old female where the average diameter is 557 minimum hole diameter. After the normal vitrectomy, I started making ILM flaps, which are made with the conventional technique, making inverted ILM flaps. So 3 hinges were made in this particular case. They were hinged at the edge of the macular hole, and this was followed by a little larger concentric peeling of the ILM. Now you can see the PFCL bubble is injected, and notice immediately, just coming in contact with the ILM flap has changed considerably. It is very sticky now, it is easy to maneuver, and it is important to just place the flap over the hole and not really stuff it inside. Now fluid air exchange becomes very important here. It is very important to remove the entirety of the fluid before you touch the PFCL bubble, so that the fluid does not, there is no remnant fluid at the end of it, and you get a very good closure. So this is the first case, and this encouraged me to try this case further, this method further. And then we did a retrospective study in our own center where we operated on 57 eyes in total from March 2020 to July 23. 36 eyes were operated with this technique and 21 with the conventional ILM flap. All of them were idiopathic macular holes, more than 500 microns minimum diameter, and all the other factors were comparable in both the groups. As you can see here, 600 microns is the minimum hole diameter average, which was there in both the groups. What was compared was anatomical closure, type of closure, and gliosis. Gliosis because we wanted to make sure PFCL is safe to use in these patients. And this is a hole which, the above is the hole which is not closed, then there is one with type 1 closure, type 2 closure, and the last one shows gliosis. So coming to the results, I did astonishingly achieve a 100%.
Please finish your time.
A 100% closure rate in this group, and type 1 closure was very good in this case as well. So why do this? Because we want predictability to close any kinds of hole, medium to large size holes, and most importantly, you want a good night's sleep. So thank you. This brings me to the end of the presentation.
Why do you need to put this PFCL? Because in any case, the multiple layered flap is going to close the hole.
So this is just, like I said, we already achieve a 90%, more than 90% success rate. It is about going from the 90 to 100%, where even if one single case where we have a flap related complication,
But
we don't have it with this technique.
in order to reoppose this whole flap into the hole, we are injuring...
No, I'm not stuffing it inside. I'm just placing it over the hole.
Okay.
There is no stuffing. It is only placing it.
Okay.
So everybody should also remember this, that there's nothing like 100%, okay? Thank you very much. So
close to 100%. Yeah.
Thank you. It's just a comment. It's not a question for you, because you guys have to go back. You don't have to carry the wrong impression of this. So with holes of these size, 400, 500 microns, honestly, inverted flaps are also not necessary most of the times. There are criteria laid down. Some people do use inverted flaps for almost all their holes, but it's essentially for larger holes, holes that are perhaps more than 600, 800, 1000 microns. And again, a very nice technique, but you have to weigh the benefits also of putting in PFCL and then doing all this entire procedure. Please, Dr. Aditi.
Yes. Very good afternoon to everybody present here. Myself, Dr. Aditi Joshi. I'll be presenting my paper on a new foe in endogenous endophthalmitis. So a 13-year-old male presented with right eye gradual diminution of vision since 1 month. He denied history of trauma, systemic illness. He was already diagnosed elsewhere as hypopyon uveitis and treated with topical and systemic steroids. His entire uveitis workup revealed a negative MON2 test, a normal ACE enzyme, a negative serology for syphilis, and normal chest X-ray. So on presentation to us, his vision in the right eye was perception of light, and in the left eye was 6/6 N6. Examination of the left eye was unremarkable. The slit lamp examination of the right eye revealed circumcorneal congestion, multiple iris nodules, large mutton fat KPs, and fluffy exudates over the iris and cataract. The ultrasound B scan revealed presence of dense, hyperreflective echos with membrane-like echo in the vitreous cavity in the right eye. So a suspicion of endogenous endophthalmitis was made, blood and urine samples were sent for culture, and anterior chamber paracentesis was performed. The anterior chamber tap revealed gram variable bacilli. Smooth, flat, grayish colonies with few microcolonies were observed. The organism could not be identified by routine biochemical tests. Based on the sensitivity report, the child was started on parenteral antibiotics and was planned for lensectomy and vitrectomy. So this is a intraoperative video showing after collection of the undiluted vitreous sample and after lensectomy. Here we see fluffy white clumps of pre-retinal exudates in the periphery and mid-periphery that were being aspirated. The gram stain revealed plenty of neutrophils and gram variable bacilli. On culture, similar flat grayish colonies showing a few microcolonies were observed. So to identify the organism, we performed sequencing of the 16 sRNA gene. The 16 sRNA genes were amplified by PCR. The bacteria was identified as Pianibacillus latus, showing a 98% homology match with the NCBI database. The bacteria were sensitive to vancomycin, amikacin, cefotaxime, ciprofloxacin, and resistant to ceftazidime and tobramycin. Blood and urine cultures were negative. 2 weeks after surgery, the patient developed rhegmatogenous retinal detachment with a small temporal blade. The patient underwent a second surgery with endolaser and oil tamponade. The patient was followed up at 4 months. There was silicone oil emulsification. The fundus was stable. He underwent oil removal with secondary intraocular lens implantation in the ciliary sulcus. BCVA at follow-up was 6.9 with a pressure of 10 millimeters of mercury. So, Piani bacilli are gram-positive aerobic bacteria that are related to the Bacillus species but differ in the DNA encoding. The genus consists of more than 100 species. Human infections with Piani bacilli are being reported with increasing incidence. Due to improved testing and identification, it appears that these infections may not be as rare as once perceived. Majority of these infections occur in setting of immune compromise or secondary to trauma. There is a single report of P. gluconolyticus causing keratitis and P. alveoli causing endophthalmitis. As we all know, endogenous endophthalmitis is a devastating cause of vision-threatening ocular infection. Compared to an adult, in children it is quite rare and it often masquerades as orbital cellulitis, uveitis, leading to a diagnostic delay. There is a diverse spectrum of pathogens implicated in infectious endophthalmitis with reports of rare and emerging microorganisms increasing. A major reason for these novel findings is because of developments in the microbiological and diagnostic methods. Our patient was initially diagnosed with uveitis with clinical signs were challenging to differentiate from uveitis. In addition, the absence of any recent history of systemic illness, surgery or trauma or intravenous medication in an otherwise healthy child made the diagnosis of endophthalmitis quite challenging. From review of literature, we could find only one other case of P. lattice infection where it was isolated from a case of bacteremia. So our case highlights the use of 16S RNA gene sequencing as an accurate method to identify rare pathogens. It also underscores the importance of reporting gram-positive spore-bearing bacilli and not ignoring the isolates as possible laboratory contaminants. This is the first report of P. lattice as a pathogen in humans causing endophthalmitis, mimicking granulomatous uveitis. The inability of gram stain and biochemical tests to identify the bacterium was overcome by using newer techniques. These are my references. Thank you.
Thank you.
Thank you, sir.
Next speaker is Dr. Liz Mary Santosh. Real world experience of switching to aflibercept in PCV cases refractory to other anti-VEGFs.
Our study was on the real-world experience of switching to aflibercept in PCV cases refractory to bevacizumab and ranibizumab. I have no financial interest. So there were a lot of newer anti-VEGF agents are being introduced with the hope of increasing treatment interval, reducing the treatment burden, and also to have better visual acuity gains. Prior to the use of advent of aflibercept, most patients diagnosed with PCV had limited anti-VEGF options, and a prolonged use of these agents often led to a possible tachyphylaxis. So the aim of our study was to evaluate the real-world visual and anatomical outcomes of PCV patients who were switched to aflibercept due to persistent disease activity after long-term treatment with bevacizumab or ranibizumab, and to compare the number of injections required during the course of each treatment. So this was a retrospective EMR review of PCV cases from January 2014 to January 2022. So angiographically confirmed cases of PCV who had received at least 3 injections of intravitreal bevacizumab and ranibizumab and continue to show persistent disease activity, either clinically in the form of hemorrhage or OCT in the form of persistent fluid or a drop in vision, were switched to aflibercept 2 mg on a PRN basis, and having at least 12-month follow-up were included in the study. The patients who had undergone photodynamic therapy or had any other vitreoretinal disorders that might interfere with the macular structure or function were excluded. So the patients were evaluated at 4 different time points: at baseline, which is at the time of diagnosis. Then the patient was started on the initial drug, either bevacizumab or ranibizumab, and then just prior to switch, then 1 month post switch, and last follow-up. So the parameters analyzed were the BCVA, intraocular pressure, fundus examination, a detailed spectral domain OCT, and the OCT parameters analyzed were the central macular thickness from the ILM to the RP, the maximal height of lesion at the that is the retinal thickness at the maximal height of the PED height, the presence of IRF, SRF, and the number of injections received during each treatment course was analyzed. So total of 14 eyes of patients aging from 64 to 84 were studied, of which 8 were male and 6 were female. So the patients were on bevacizumab, the initial injection, for a period, mean number of at least 25 months plus minus 19 months. A mean number of injections received during this period was 7.57, and the patients were on aflibercept for at least 20.71 months, and the mean number of injections received during this period was 6. So the trends of change in vision, the patient had, during the course of the initial injection, the patient had a slight drop in vision, and just post-switch, there was a significant improvement in vision, and there was, up until the last follow-up, the patient had a better acuity than the baseline visual acuity. The CMT change also showed similar trends. The CMT was almost maintained, almost the same during the initial course, which dropped drastically post-switch, 1 month post-switch, and which dropped further up until the final follow-up. The maximal height of lesion also was progressively increasing during the course of the initial treatment, then showed a drastic reduction post-switch to aflibercept, and which was maintained up until the last follow-up. The height of the PED also was progressively increasing during the initial time of bevacizumab or ranibizumab, and showed significant improvement 1 month post-injection, and which was maintained up until the last follow-up. So the patient was on in the initial treatment for a mean number of 25 months, and the mean number of injections received during that course per year was 5.19. And post-switch, the patient was followed up for another 20 months, and the mean number of injections per year during post-switch was 4.01. So this is a representative case of an angiographically diagnosed case of PCV, and at 2015, at diagnosis, the patient had the initial picture, the first OCT image, and October 2020, just prior to switch to aflibercept, the patient had persistent disease activity and a progressive disease. In 1 month post-switch, there was a significant reduction in the PED height and the disease OCT parameters of the disease activity. And 2 years post-switch, after 8 injections of aflibercept, after a 24-month follow-up, the patient almost had a completely dry macula. So our results suggest a significant improvement in anatomical outcomes post-switch to aflibercept, which was maintained over a mean period of 20 months. And this trend was almost shown in the BCVA, and it was maintained up until the last follow-up. And there was a modest reduction in the number of injections required per year. So even on a PRN regime, post-switch to aflibercept, the results were favorable in terms of anatomical and visual outcomes. So there was a similar study over a 6-month follow-up, which showed a similar result. This was a retrospective study. There was a low case number, but with strict inclusion criteria. Our strength is a 20-month follow-up post-switch. These are my references. Thank you.
Charu Magul, last.
Thank you.
Move on to the next one.
Thank you.
Dr. Charu, yes.
Yeah, healthy good afternoon, everyone. So before I start, I want to thank Punjab Ophthalmic Society to select my paper as the best of the state. So today I'm going to talk about the role of primary vitrectomy for the management of the subfoveal hard X-rays. So it has been, slides are not moving, sir? Slides are not moving. So it has been known since many years now that these subfoveal exudates, they are the common cause of the severe and irreversible vision loss in the patients of diabetes. They lead to RP scarring and the subfoveal fibrosis. So since then, many treatment modalities have been used for treating these subfoveal exudates, ranging from focal lasers, but these exudates, they respond really poor to them. Then came the era of surgically excising these subfoveal exudates, but it was found to be technically very demanding and complicated procedure. Then came the role of vitrectomy for these subfoveal exudates with a certain supporting facts that vitrectomy helps to remove the tractional forces, it reduces the oxygen consumption, it reduces the hypoxia, it decreases the VEGF load and also help to remove the vitreous collagen. So with the help of this retrospective interventional case series, we tend to delve the role of vitrectomy, but along with ILM peeling for the management of these subfoveal exudates. So record of 11 under 33 eyes were retrospectively reviewed who underwent the vitrectomy for the complications of diabetic retinopathy from 2019 to 2021. 66 eyes of 66 patients which fit the inclusion criteria, they were included in the study. The plaque size as shown by the fundus photo below was measured with the help of the measuring tool available with Claris 700 fundus camera. The inclusion criteria for my study was the presence of these subfoveal exudates with the preoperative visual acuity of less than 6/18 with a good preoperative metabolic control for at least a duration of 3 months and with a minimum follow-up period for at least 6 months. We observed that the mean age of my study group was 57 years and the mean follow-up was around 13 months. Equal proportion of the cases fell into the category of NPDR and PDR and the lens status was majority of the cases were pseudophakic. OCT did reveal vitreofoveal tractions and taut posterior hyaloid in few of these patients and majority of the patients have already received the intravitreal injections and the lasers before doing this surgery. So the mean of the best corrected visual acuity preoperatively was found to be 5/60 which after the surgery got improved to 6/36. 47 out of these 66 patients showed the improvement in the vision. With 13 patients, they got improved to equal or better than even 6/18. The preoperative plaque size was found to be 2.172 millimeters square, which got improved to 0.26 millimeters square. And the fundus photo below is showing the representative case of the largest plaque which was operated, and it is showing the complete resorption of these subfoveal exudates with a duration of 6 months. We kept a very keen eye on the status of the other eye, though in majority of the cases it remained the same, but in very few of them it actually got worsened. So this is a representative case in which the left eye of the patient was operated and it is showing the resorption of these subfoveal exudates, while in the other eye we can see as we are following the patients the disease got worsened. 100% of the patients showed the resorption of the exudates with 18 patients showing the complete resorption, and cataract turned out to be the most common complication of my study. So this is a representative case of a 64-year-old male which is showing the resorption of these exudates with the duration of 8 months, and the vision is getting improved from finger counting 1 meter to 6/12. Another representative case which is showing the resorption in a duration of 14 months with the vision getting improved to 6/9 from 6/36. So vitrectomy alone has been done previously, but in that ILM peeling was not done along, and the resorption could be seen at a duration of 3 months. In that study, none of the patient got improved to better than 6/60. But in our study, we have combined ILM peeling with vitrectomy, and the resorption could be seen as early as 3 weeks, with 13 patients getting improved to even equal to or better than 6/18. So here comes the role of ILM peeling. ILM peeling ensures the complete removal of posterior hyaloid. It ensures the removal of the part of the Muller cell foot plates, which lead to the cascade of the chemical events that helps to fight against the breakdown of blood retinal barrier and also helps to repair the interruption of the exoplasmic flow. ILM peeling ensures increase the release of EGFR, which acts as inhibitory to the VEGF. So compared to the surgical excision, vitrectomy with ILM peeling is a routine retinal surgical procedure with lesser complications. The limitation of my study is that it's non-comparative. So I would like to conclude that vitrectomy with ILM peeling is a simple and effective way to manage these subfoveal exudates, but we do need prospective randomized control trials to substantiate my finding. Though it is not a primary treatment option, but it could be considered in the cases which are resistant to the therapies before the damage has occurred. Thank you so much.
Just peeling, no? Thinning through. Okay. Thank you, ma'am.
Thank you.
Okay, thanks so much.